So whatever is the plan according to that.
Perfect.
थोड़ा सा मैं बोल रहा हूँ तो मेरे को नॉइस आ रहा है, कम करो ना। अच्छा सर। हेलो हेलो माइक टेस्ट 1 2 3। हेलो हेलो, ठीक है अब सही है, अब सही है। हेलो, ठीक है अब सही है। वो मैं फाइबर लगाऊंगा, फाइबर लगाऊंगा, नंबर ले लो साथ आपको।
Right? Hello?
Hello? Yes, sir.
Yeah, so you audible?
Yeah, very clear.
Okay, yep.
So we are starting here.
Okay, so are we.
Good morning. On behalf of the Departments of Neurosurgery and Neurology, we welcome you to the All India Institute of Medical Sciences and to the city of Jodhpur. We have gathered here for the midterm CME of the Indian Society of Functional and Stereotactic Neurosurgery. DAY-1 proceedings will begin with live operative demonstration. There is a simultaneous botulinum toxin workshop which is going to be held in the examination hall at 9 a.m. For the operative demonstration, we have two cases being operated today. The first is a patient with temporal focal cortical dysplasia, planned for anterior temporal lobectomy and amygdalohypocampectomy, who will be operated by Dr. Aditya Gupta. And the second is a patient with multifocal periventricular lesions, planned for stereotactic biopsy, and being operated by Dr. Milind Sankhe. The session will be moderated by Dr. Dwarkanath and Dr. Arivardan. To discuss the first case, I call upon Dr. Pankaj, who will be presenting the clinical findings.
Good morning, everyone. Starting with the first operative case for anterior-temporal lobectomy and amygdalohypocampectomy. Patient is 17-year-old male. The age of onset of seizures is 6 years of age. The total duration of the seizures is till now 11 years. Frequency of seizures is 10 to 15 per month. There is no history of febrile seizures in the past, and the patient has normal birth and developmental history. Seizure semiology: the patient has sudden onset behavioral arrest without any preceding aura, followed by early vertigo head deviation to the left, along with the picking hand automatism more in the left hand, lasting for 5 to 10 seconds, which is followed by some confusion and irrelevant talk for the next 4 to 5 minutes. These episodes were never associated with secondary generalization or tongue bite or urinary incontinence. Currently, the patient is on 4 antiepileptics: Oxcard, levetiracetam, lacosamide, and clobazam. Patient is neurologically intact, perimetry is normal. This is the interictal EEG, which is showing T3 spikes with phase reversal in the left temporal. This is the ictal EEG of this patient, which is showing fast activity in the left T1, T3, T3, T5, and T5-O1. This is the video of this patient. There is the early head version towards the left, sudden behavioral arrest, along with the left side automatism, left hand automatism, and there is a paucity of the movement on the right side. This is the MRI of this patient. The first two slices are showing there is a grey-white matter disjunction at the left temporal pole, along with the left focal cortical dysplasia. Along with there is atrophy of the left temporal pole. We can also see the atrophy in the sagittal, that is, the atrophy of the left temporal pole is present. On sagittal, we can see there is a enlarged amygdala on the left side. However, the hippocampus on both sides appears to be normal, and the temporal horn is also normal on the both sides. On PET scan, we can see there is a hypometabolism on the left side. So to summarize, based on semiology, the lateralization is left hemisphere in view of early left head version, left hand automatism, and localization is medial temporal lobe in view of behavioral arrest and left hand automatism. On EEG, it is localizing to the left temporal. MRI is showing left temporal focal dysplasia along with the enlarged left amygdala. And on PET, there is a left temporal hypometabolism. Plan for this patient is left anterior temporal lobectomy along with amygdalohypocampectomy. Now I would like to invite Dr. Aditya Gupta for the operative plan. Thank you.
Good morning, everyone, and first of all, thank you for the kind invitation to the Aiims Jodhpur neurosurgery team and for the warm hospitality. I think this is a very interesting case. So to recount, and we know that for the ISSFN CME, our basic approach and tone and what we want to convey is a very, very basic level of teaching. So if we start from the basics, so a couple of things are very, very clear from the history. This patient has long-standing, medically refractory epilepsy. So the duration of epilepsy is 11 years. And if you looked at the kind of drugs this patient is receiving 4 anti-epileptic drugs in nearly maximal doses. Now, the basic dictum, rule of the thumb which we follow is, as you know, is a rule of 2. So, in an adult patient, patient with refractory epilepsy, at least for 2 years, with at least 2 anti-epileptic drugs which have been tried in good doses with good compliance, and at least 2 seizures happening every month, which are disabling. So all these very simple to assess criteria are what we employ in at least filtering out patients which are then put in the pipeline for evaluation for a possible epilepsy. Now, this patient, in fact, we were examining and counseling this patient yesterday. So this patient, because of the long-standing 11 years history of refractory epilepsy, has a very clear intellectual decline as well. The father was recounting that when the child was in grade 1 or 2, he used to be the brightest, among the brightest students in the class. And to the extent now that this young man now has a loss of confidence, impaired school performance, impaired intellectual function. So this is the kind of harmful effects that chronic uncontrolled epilepsy produces in the function, neuropsychological function of a person. And these are exactly the kind of people actually who would be and should be selected for epilepsy surgery, actually very early. Now, it is actually a reflection on how things are still in our country, that these kind of patients are coming to us, in this case, for example, after 11 years of uncontrolled epilepsy. And a few words about surgically remediable symptoms. So, what we need in these patients, the two important investigations that we need is a video EEG and an epilepsy protocol MRI. Now, many of these patients are advised to have a CT and a normal standard brain MRI to be done, which may not show these subtle findings which you saw in this case. Now, epilepsy protocol MRI, basically, the two things important in that are, there are some sequences which are done with a very high resolution to pick up the kind of changes which were demonstrated. For example, if you look at this MRI, for example, the subtle changes which are seen in the basitemporal lobe on the left side is not very easy to make out. And if you look at the left side, the classic changes of cortical dysplasia with the fuzzy gray-white differentiation. So these are many times missed in a normal MRI. Additionally, what is always done in an epilepsy protocol MRI is that the coronal sequences are taken in a certain angulation so that the entire hippocampus from anterior to posterior is visualized very clearly. Now, in this case, if you notice, the evaluation is very neatly fitting in. The clinical kind of seizure this young person is having is fitting in very nicely with what you find on the MRI. And it's also fitting in very nicely with the PET scan. And all in all, that's what we call as a concordant pre-surgical epilepsy evaluation. And in this case, because everything is fitting in so nicely, therefore, we would say that this case is an appropriate case for taken up for epilepsy surgery. Now, the slightly unusual thing in this case is that you do not find a very great deal of hippocampal atrophy. So, hippocampal atrophy, if you see the coronal images, is very subtle. There is a very mild loss of the interdigitations of the hippocampus on the left side. Do we have a pointer here? So there is a very subtle loss of the interdigitations. And if you see the middle image at the bottom, there is a very faint, very subtle atrophy of the hippocampus, which is not as florid as one would expect after 11 years of uncontrolled temporal lobe. Now, with the anatomic substrate that we are talking about is basically cortical dysplasia. So my approach in this patient would not be to simply do an electrocorticography guided focus resection, which is what we would do in an extratemporal setting. In a cortical dysplasia, and especially in these kind of epilepsies which begin in the childhood, the surgical dictum is to be more radical and more aggressive in your surgical approach. And therefore, what I would do is a classic anteromedial temporal lobectomy, and in which basically, if I can summarize the surgical strategy, would be to spare the superior temporal gyrus, which you see here, come in from just beneath the superior temporal gyrus, enter the temporal horn, and remove the hippocampus, and then go around to the collateral sulcus, remove part of the fusiform gyrus here, and complete the anteromedial temporal lobectomy. So this is the overall surgical strategy of doing an anteromedial temporal lobectomy. It has been well described by numerous authors. There are numerous techniques, numerous variations, but this is the basic technique which has withstood the test of time. There are a number of variations. So for example, we know that Yasargil described the selective transsylvian amygdalohippocampectomy. We are in the operative field. You will easily understand how that can be done and how we would approach that kind of a procedure. Then there are a number of variations. For example, some people prefer to enter from here, just above the inferior temporal gyrus. And some people choose approach which is a transcortical through the middle temporal gyrus. So there are a number of variations, but I think the net result is pretty much the same. A word about the epileptogenic zone. Now in epilepsy surgery, in the classical text, you see a number of zones that are described. There is an ictal onset zone. There is an epileptogenic zone, which I believe is the most important part of any epilepsy surgery. And epileptogenic zone is that volume of tissue which is necessary and sufficient to produce the seizure. So basically, that is the tissue which has to be removed for us to achieve seizure freedom. But it is actually a theoretical construct because it could vary from case to case. Now, in a pure MTS case, you could actually go ahead and describe the epileptogenic zone, but it would basically not have very clear demarcations because there is no way that we have to exactly demarcate the epileptogenic zone. Now, with SEEG being used even in temporal lobe epilepsy, which I personally think is an overkill, maybe in a few years' time somebody will actually describe that in a pure MTS case, this is exactly what you need to remove. But till such time, we continue to follow which has been described in the classical papers starting from Spencer and the other descriptions of a classic anteromedial temporal. So this is pretty much what my approach would be in this particular. So I would be happy to take any questions, comments, discussion.
Dr. Aditya nicely described. Just to raise queries and make it more clear. For example, in this case, it's not like you said, it's not a classic case. Here, this is the dysplasia of the temporal pole. Maybe you can address why hippocampus need to be removed in this case. The hippocampus is not screened. Why not only the leaf? And how will you decide in a temporal lobe pathology? When does hippocampus need to be removed? When can be screened?
Yeah, so see, there are no hard and fast guidelines. What I would say is pediatric age group is one criteria. The other is what is the basic pathologic substrate. So in this particular patient, it is a pediatric onset epilepsy, started at 6 years of age. And the basic, the pathologic substrate is cortical dysplasia. Now, cortical dysplasia is unfortunately an entity with a modest long-term outcome. if you look at the series of extratemporal cortical dysplasia, the 10-year seizure freedom Engels grade 1 outcome is only in 50%. In temporal cortical dysplasias, it is a shade better. And this is exactly the reason why it is a shade better, because most of the temporal cortical dysplasia series, the authors would have actually done an anteromedial temporal lobectomy. So when we are faced with a substrate like a cortical dysplasia, personally I would be very hesitant to just do a electrocorticography guided focused resection as we do in the external.
So the same, in continuation, because this is focal cortical dysplasia, the problem with the dysplasia is it is usually more than what we see in the scan. If it is hippocampal sclerosis, we know the hippocampus is involved, so you remove the body and the head, so you get a good control. Here, what we see is the fuzzy or loss of gray white differentiation in the temporal pole, but it is possible that it can extend beyond what is seen in MRI.
Absolutely.
And that is why we have to remove the hippocampus. Probably my concern is that even the extension of the temporal lobectomy also may need to be guided by ECOG. If you can show the PET here, the PET hypometabolism is far more posterior. If you see that sagittal, the hypometabolism in the PET is beyond 4 centimeters in sagittal. But that should be taken with a rider that usually the hypometabolism in PET is beyond the actual epileptogenic zone.
Yes.
So you don't have to chase the PET hypometabolism. It should give us a clue that it is not just a focus to the pole, but it does not require that we need to remove all the hypometabolic zone, because PET always over demonstrates the actual areas of epileptic zone. So my question is, would you also like to do ECOG? I mean, you don't have to.
Yes.
I mean, we will not restrict only the polar resection. Hippocampus and amygdala will have to come out. But for the posterior limit of the temporal lobe resection, would you also consider ECOG?
Absolutely.
I mean, pre and post resection ECOG can give
Absolutely. We would do a ECOG to determine the posterior extent of the resection. And this is a left side AMTL. So I would begin with a 2.5 or a 3 centimeter resection initially, and then later on we'll see how it goes. The other interesting thing is PET, as Dr. Ari correctly suggested, that it always overestimates the hypoperfusion, because that is a secondary phenomena which you see after an event has happened, and after the seizure has happened, there is a residual hypometabolism in the chronic epilepsy cases. So actually interictal PET is picking up the residual hypometabolism in that temporal. Now, a more specific test is an ictal SPECT. So if I have to name one test which can actually demonstrate the epileptogenic zone in a particular epilepsy case, ictal SPECT would be what would need to be done. But in these kind of reasonably straightforward concordant cases of a temporal lobe epilepsy, I would say ictal SPECT is really not warranted. The pre-surgical workup which you see has been done is actually quite enough and quite appropriate for this particular.
So, just to continue with the discussion, Aditya, would you like to highlight the role of preservation of the temporal stem, particularly on the left-hand side when you're operating? You mentioned the various approaches. One is the trans-Sylvian approach, one is the trans-middle temporal gyrus approach, one is the inferior temporal gyrus approach. And I thought our coronal images were quite, convenient to discuss that. Particularly since we are operating on the left side, the preservation of the role of the temporal stem as such. I want to discuss that.
Would you want to describe that, and then I can just carry it on? What do you do to preserve the temporal?
So I use the coronal suture line, coronal images as a guideline but the idea is to try and make sure that particularly one of the and the literature describes this, that if you're trying to do anything on the left hand side, preserving the temporal stem is more important, because eventually the white matter outflow is going to have from the temporal stem, and also from the STG is going to go from the temporal stem. So the transition approach, particularly if you are going to go really even about beyond 3 centimeters, becomes a little difficult, and to preserve the outflow through the temporal stem. So just as you mentioned the names, including the Yazagal's approach, the Nema's approach, as well as the Park's approach, the advantage of a Park approach, or for that matter even through the middle temporal gyrus, is that you essentially are avoiding any injury to the temporal stem. And I personally prefer, depending upon the side that I am doing, but if I am on the left hand side, I like to go through the left middle temporal gyrus. Obviously we all do the same more or less once you are there, but the advantage of that being that I have a clear understanding as to where my temporal stem is. So this is just to initiate further discussion.
So what the other thing which is very important to understand is, if you look at the coronal images, what I always like to do is never enter the temporal horn in that direction. I always like to enter the temporal horn from this direction. So that is the strategy which I use to preserve the Myers loop. And actually, when you are in the temporal horn, what you see on the medial side, anterior to the tactile plate region, that area is not very far from the lateral geniculate body. So basically, as you enter the temporal horn, the lateral geniculate body is actually not very far. So the Myers loop, which is somewhere here, if you approach it from this direction, it's very easy to interrupt these Myers loop fibers as they are going into the lateral geniculate. So my approach would be the direction that you use to access the temporal horn should be as basal as possible to preserve those superior fibers. Now the other important thing is, if you are having that kind of a trajectory, especially anteriorly, you can land up very close to the optic. That is another very, very important surgical step to avoid going in that region. So the optic tract, Myers loop, lateral geniculate body, one has to be mindful that you are actually working very close to. And once you're in the temporal horn, of course, we will see intraoperatively that anatomy. It's not very difficult to get confused as to what is the hippocampus, where is the parahippocampal gyrus. And it's very important to take some time to orient yourself as to what is what once you're inside the temple. So I think, should we go to the other case or?
Any other?
Hi.
It was a nice discussion. Just to add, for one of the approaches by Professor Ugur Ture, he had described the posterior fossa approach, supracerebellar and infratentorial, to avoid the temporal stem and also these optic tract fibers. So he just goes from beneath and then removes the whole of the hippocampus.
Yeah.
So that is one approach that can also be tried, especially in the tumor-related cases where there is a glioma which extends. Sometimes it's a mesial temporal glioma which goes all along the hippocampus and then back.
Right. Probably more relevant in cases with the visual fields are already involved and the non-dominant side basically. But that's a very nice approach as well, and as you rightly put it, in the tumor cases. And in fact, that is the approach from which actually you put depth electrodes into the hippocampus. Because you see, you have the entire length of hippocampus, you are going along that entire length of the hippocampus. That's also a very interesting. So I think somebody, sorry? Yeah, so I basically like to place the position supine with a slight head turn and a small incision. That of course, those details we probably will explain once we are in the office. So just a simple supine head turn position and basically standard neurosurgical equipment, nothing fancy except for the ECOG, of course. So I think should we?
Hello.
Yeah, hi Bhaskar.
Yeah, morning. We are all set. So I guess you can carry on with the rest of the discussion once you are here.
Perfect. Yeah, we'll do that.
Yeah.
Okay. Thank you.
Okay. Thank you.
So to discuss the next case, I call upon Dr. Jwalit, who will be presenting the clinical findings.
Good morning, everyone. The second case is a case of periventricular lesion. 63-year-old female, housewife occupation, presented with history of 3 episodes of focal motor seizure involving the right lower limb since the last 6 months. History of occasional headache, history of altered behavior, irrelevant talking for the last 2 months. There are no features of raised ICP. The patient is a known case of hypertension taking metoprolol, hypothyroidism taking on thyroxine 87.5 microgram OD, and also a case of anxiety disorder on tablet quetiapine 25 milligram OD. There is no other significant medical or surgical history. The family history is not significant. The vitals are normal. MMSE is 22/30 with impaired attention, calculation, recall, and language. Vision is 6/9 bilateral eye and no focus present, no papilloedema, and no other neurological findings are positive. Coming to the radiology, the T2 and T2 flare shows the periventricular lesion involving the body of the corpus callosum. Here, left side splenium extending into the corona radiata with perilesional edema extending into bilateral subcortical, parietal, and occipital lobe. There is also a small lesion noted in the left cerebral hemisphere. The diffusion shows the restriction in the periventricular area and low on ADC. On the contrast imaging, the lesion is brightly contrast enhancing in the periventricular lesion, in the periventricular area and the corpus callosal area, which is extending more towards the left side. The MRI shows creatinine and choline peak and also the lipid lactate peak. So the summary is the patient presented with right focal motor seizure and altered behavior since last 6 months, with radiology most probably showing the periventricular lesion, more probably a lymphoma, and the plan of the patient is stereotactic cardiac biopsy. The operative plan would be discussed by Dr. Milind sir. Yes.
For the first time on the podium, I felt I was a little short, so I had to use this tool. It was the first thing was the patient. The diagnosis that we are seeing over here is more likely to be a lymphoma rather than standard butterfly glioma. So the first instructions that probably comes out from a surgeon's point of view is that please do not start steroids before a biopsy is done, because simply the moment you start steroids, it's going to be difficult to try and visualize the lesion as well. The other thing is I like to do these sort of biopsies under MRI guidance, preferably because it's much easier to spot
these and locate these. CT scan might be difficult to pick it up. But having said that, we are planning to do this one with the CT guided biopsy. The reason is that this patient is extremely anxious, very, very apprehensive, though she consented to do it under local anesthesia yesterday. But I think the anesthetist also saw her and she has fear about even some basic injections as well. So in a situation like this, we obviously have a couple of options, whether it is going to be a frame-based or a frame-less, a navigation-guided biopsy. So for all the basic principles that we know, anything which is more to the surface, navigation is more useful, whereas anything which is more deeper, a frame-based stereotactic procedure is much easier to perform. This being where it is much, both the options are possible, but obviously I think a navigation or a frameless stereotactic biopsy in a situation like this may be using too much equipment, where frame-based, which is a bit much more basic principles and a more rigid option, probably easier to use and safer to use as well. So I'm sure all of us have been using the stereotactic frames. So for those, I don't really see many juniors around, so there's not much point in discussing the basics of stereotaxy as such. But if we consider the basic principles of a Lexel frame as such, which tends to differ from the CRW frame, that in the CRW frame, the 0 is in the center of the frame, whereas in the Lexel frame, the 0 is in the right posterior superior corner. So as long as this basic understanding about the frame is you're aware about, in the Lexel frame, everything is 100 as far as 0 is concerned, whereas in the CRW frame, the center of the frame is 0 from all coordinates point of view. We are all aware about the principles about not crossing two PL planes, making sure that you pick up a trajectory which is not going to go through a sulcus. All these things become very, very useful. But as far as the stereotactic biopsy for a lesion is concerned, try and pick up certain things such as an enhancing area rather than a non-enhancing area. Always try and study the characteristics of a tumor to figure out what is going to be the vascularity, what is going to be the consistency of the tumor. Something which is more vascular, likely to please discuss the possibility of a bleeding or a hemorrhage at the surgical site and mentally prepare them, which was done yesterday. We actually did mention this to the patient's husband about it. So I must admit that you don't really expect much of a bleeding in a situation like this. The second principle that I follow is that you should be able to hit the target within the first biopsy or the first approach itself. And the second approach is just to get more tissue rather than multiple sites, which is something which was described initially when I was a resident. I remember we used to talk about multi-quadrant biopsy, which is not anymore. Make sure that you have one representative tissue from the most possible malignant area, which is radiology guided. This obviously has a significant advantage. Doing multiple quadrant biopsies is not something which is risk-free, and particularly the risk of hemorrhage increases with the number of trajectories or the number of approaches, targets that you make. And at the, as the basics clearly suggest, that you please ensure at every biopsy that you have intraoperative frozen to try and tell you, if not a definitive answer, at least that you have a pathological tissue. If you have a pathological tissue, at least you know that your procedure is not gone down the drain. It is not unusual that in the past, frozen section was not done, and unfortunately, the tissue was not representative of the pathology, and it means that you've conducted a procedure and there's absolutely nothing in your hands at the end of it. Complications wise, the most important complication in a procedure like this is hemorrhage and hemorrhage. Nothing more. But stereotactic biopsy overall is an extremely safe procedure with a yield of almost about 96%, even in the days when it was not such an advanced technology. I remember way back in 1993 was one of the first papers that I read in Dublin at the meeting where I presented data of almost 132 cases. And the yield of the biopsy in a properly conducted was as high as 96%. Now one can say that this is probably, very tumor-based study, but so be it. We are talking about tumor-based study as far as stereotactic biopsy is concerned. Now navigation has become so advanced, you find your trajectory from all aspects, all possible corners. Just a short while ago, about how you could reach the middle temporal gyrus through the posterior fossa. So now we are at a stage where stereotaxy allows you to place electrodes through the occipital route into the hippocampus. Similarly, in the earlier days when TBS was just being introduced, even in days, some of the spontine lesions were being biopsied through a precoronal burr hole. And I remember that presented their which are biopsied through a precoronal frontal burr hole. So, why am I saying this? The versatility of doing a frame-based procedure should not be lost. Extremely useful piece of equipment even in the days of navigation. It is something which is very, very useful even if you do not have a radiosurgical unit. Very easy, a very, very basic tool and basic equipment for everybody to get their hands on. Cannot make a mistake. The only concern that comes with a frame-based procedure is if you're really talking about a very, very odd approach, particularly if you're talking about something which is extremely temporal and slightly more superficial, then getting something through a leg cell frame can become very, very difficult. So you really need to have a position of the leg cell frame completely crooked and one-sided. Similarly, to try and do something which is in the posterior fossa, you need to understand that you may have to place the frame differently so that you don't have the arc coming in your way. So instead of having it, you will have to change the X and Y axis of the frame. So these are some of the limitations which are from a with the leg cell frame. And that's where, as far as this patient is concerned, the procedure is planned or was planned under local. We are going to do it under general anesthesia. Now this patient is being put to sleep. It's a straightforward supine position with left-sided, slightly posterior frontal burr hole, given that I do not want too much of an angulation to happen, because the more the angulation, chances of your entry point and your target preferably are in an alignment of about 90-degree perpendicular to the tangent of the skull. So after routine preparation and draping, it would be a straightforward burr hole. First trajectory straight into the lesion on the left hand side, and the second would be to try and get more tissue, and that should be the end of it. Complications wise, hemorrhage is the main thing. Generally, as such, these patients would be under local anesthesia, so they don't have much of an option to recover, and the steroids would be started immediately as soon as we are told that this is a pathological issue. For the line of treatment, obviously, we all understand would depend upon what the pathology, but given that we are suspecting a lymphoma, I suppose patient has also been counseled that there is a pretty good chance that we would be going in for a definitive line of treatment later on. I'm not sure if there's anything. Is there anything that comes to your mind? Please go ahead, and discussion can be done. Just anything that comes to your mind as well.
very nice. I mean, you have covered all the points. So, it's just a small thing. There are two types of biopsies. One is the forward cutting and one is the side cutting. So, when you into the tumor, so the biopsy needles actually have lesser amount of bleed than forward grasping biopsy. So, always preferable to use a side cutting. Second thing regarding CT versus MRI has an inherent error is much more than this. So while it might not make that much of a difference for
a larger
lesions, but for very small targets, CT is going to be inherently more accurate. So if you have a lesion which is enhancing, CT is much more accurate than the MR imagings. Third, that is because of the motion, the principle of the based on motion of hydrogen. CT is always more accurate. And even in the MRI, 1.5 Tesla is more accurate than as the Tesla increases the accuracy. One question I had to ask you was, and this was our experience in hands also, when you have a non-enhancing lesion which is predominantly seen on T2, what would you do?
So, what I do is essentially I make sure that these lesions are done under navigation, under MR guidance. And I have my T1 and T2 fused. And given the T2 fused, then I use, once I've got the coordinates based on this, then I can use the coordinates as such and use the T2 for identifying the target. But generally, even if you do have that, a 3D flare is good enough for you to pick it up. So even if you do have an abnormality which is not so well visualized on T1, a 3D flare which is seen is able to give you all the coordinates, and a 3D image can be integrated on a navigation system as well. Similarly, then you can actually have a image fusion between T2 and 3D flare, and that should also be able to do that, which is what we are doing for epilepsy.
The comment which I made, which you said, why a frame or a frameless? Again, the frame-based stereotaxy is the most accurate system. The frameless stereotaxy still has an error. I mean, depending upon what system you're using, because it is finally you're fusing space to the image, to the patient's head. The accuracy of the stereotype with the frame, because it's a rigid fixation, the accuracy is almost 0.4 millimeters. That's a margin of error. While generally when you're doing neuronavigation, you tend to accept an error of up to 2 millimeters. So a frame-based system is inherently much more accurate than a frameless stereotaxy. Again, while this might not be very obvious or not disturb you when you're doing a biopsies, when you're doing procedures like deep brain stimulation or lesioning, a frame-based procedure is inherently going to be more accurate, and that is why still the frame-based thing of putting the leads is the gold standard for deep brain stimulation.
Absolutely. So even when we are, doing a DBS, as Dwarka was saying, we are looking at, you cannot have a 2 millimeter as the range. It's too much in the cases of STN as such. Though we use navigation to try and pick up a trajectory, we do the fusion, get a trajectory plan with all this, but it is basically the coordinates are derived from the frame-based stereotaxy. And it is very, very important that you try and cut down the error when you're doing the navigation planning on a DBS as well, that you try and make sure that everything is, I try and bring it down to less than 0.05 as such, or 0.5 per millimeter. But that's something which we're not talking DBS over here. Going back to the discussion of a Sedan needle and the Nasher's biopsy needle, like to point out one particular thing which I actually missed out when I'm saying. You mentioned about the side cutting. We need to also remember that the side cutting is actually measuring, particularly on a Lexel frame, the tip is a blunt tip, whereas it's a side cutting. So you need to make sure that you're a couple of millimeters, and the side cutting needle is roughly about a centimeter long as such. So you should be taking that into account when you are picking up small tissues as well. So you got to be a little careful about that. Second thing, that there is another needle which is probably still there in most of the departments but very rarely used, is that spiral cutting needle, which is like a corkscrew needle. This used to be available in the most of the departments in the earlier days. So this was used for, and the inner thing would have the corkscrew that would roll in, and then you would have a sleeve which would cut over it, and then you would just get the tissue out. Now, this was used for firm lesions, and many years ago, even a biopsy was practiced for a firmer lesion in these days. I'm talking about 25-30 years ago as well, 30-35 years ago as well. The incidence of hemorrhage is obviously going to be more in these. Incidence of hemorrhage in this corkscrew needle is always going to be more. And these sort of pathologies eventually, and this sort of understanding has essentially allowed for this needle's use to go down. No one uses these needles anymore. Now the most popular needle for everyone to use is the side cutting needle and the Sedan biopsy needle as such. I think the names I keep forgetting. There was this Sedan, Nashers, and there were one or two other names as well. But there's a very interesting green colored textbook which came out many years ago about talking about basics of stereotactic biopsy, which includes these details on the needles as well.
So I have two things, one a comment and a question. Comment is about the side cutting needle. Normally what I do is one enhancing portion, then turn it 3 o'clock, 7 o'clock, strategize, and probably the longest trajectory.
Hello.
Yeah, hi Bas.
Hi, Dr. Milind. Just one thing. You can continue with the discussion.
Yes.
So Dr. Aditya will be marking the skin flap and showing it. So I think people can see that also. So once you finish the discussion, we would have finished that, and then if anybody has any queries, he or she can raise that. By the time we'll just go through with the marking the skin incision and then the positioning.
Sure. Okay, we'll continue the talk. We can see you on the screen nevertheless.
Sorry, I couldn't hear that.
Said we can see you on the screen. We'll continue with our discussion till then.
Yeah, please do so.
Yeah.
Thanks.
Okay.
Other question is, for the posterior fossa, how exactly do you fix the Lexel frame? I'm just curious to know whether...
So, very interesting. So, see, in the Lexel frame, we have this X, Y, and Z thing, which the sidebars comes onto the Y side of the wings, basically over here. Now, when you are doing it for a posterior fossa as such, you need to ensure that this is completely like this and the patient is positioned prone. And the whole thing has to fall behind, and there's a limitation that happens because your frame becomes slightly placed like this to try and get a good range for an approach. Having said this is something which has been done in the past. It is not unusual, and I have also done it as a resident, with obviously talking about during my residency days. The cumbersome part of it comes as to conducting a major procedure, because handling the microscope and the instruments to conduct a stereotactic guided craniotomy becomes an issue. Posterior fossa stereotactic frame based biopsy is still easily doable with the Lexel frame as well. My problem with the Lexel frame comes whenever you want to do something like an SEEG for a temporal lesion, if you want to try and put in electrodes from the lateral entry points, or not an oblique entry point, so you're talking about a transverse entry point. So the bar everything, was the way it was described is to switch the Y into the X position. And this is something which allows and brings the arc in the AP, so you essentially get the entry point into the temporal as well. The disadvantage of that is that trying to do both sides at the same time becomes difficult. Now you are thinking in terms of doing an SEG for generally if there is a query about which side is, but if you're talking about doing a temporal lobe lesion as such, it is doable by switching the frame completely so that the actual X, the X becomes Y. So you're just switching so that the arc comes like this.
That I've done, but Professor Tara used to say to put it upside down. Have you ever tried that?
No, I've never put it upside down. No.
To get one of the down to the.
So
I
was taught to put in the frame like this. Putting it upside down becomes very, very difficult. But I remember seeing, I don't know whether some of you would recall Professor Verma, I'm not talking about Ravi's dad, is a gentleman called Professor Mr. Verma, as they would call it. He was a professor in Dundee and he later moved to Liverpool. So I have seen him place the frame completely the other way around.
No, this is the...
Upside down.
Yeah, upside,
yeah. I've seen him do it once, but I found
I've seen
it
a
very,
paper,
very
but I've not seen anybody using it.
Yeah, it's very, very difficult to do that with an Excel frame.
Thanks.
That's where navigation tends to gain. Yes, hi Ramesh.
For SEG you told, we have been doing that because...
At Aiims we have a robot, but I think during the COVID times it got broke down.
We can't afford a robot.
No sir, I'm just coming to that point. During the COVID times actually it broke down, so it didn't work for 2 years almost. So we started doing SEG using the frame based, the lesson frame. And we routinely used to place, because most of our subsets used to be temporal lobe epilepsy. So, and bilateral temporal placement is a problem in Lexil frame. So we used to use it with anterior posterior orientation and then do it both sides.
Correct.
Yeah, it is a bit cumbersome and there are chances that because every time you have to have a very good team where the assistant keeps on reading it again and again.
It is not only just cumbersome from that point of view, draping the patient is also cumbersome. Everything becomes a challenge.
So that we had faced.
Absolutely, yeah.
Does the robot also uses frame or frameless?
I don't use a robot because I don't have it.
It can be used with a frame also.
So is it that accurate as the Lexil frame is? Just
based on the studies, I was also got to comment on that. Basically, based on the studies, they have shown that there are a couple of papers which have shown even higher accuracy compared to the frame-based with the robotic ones. It's a principle of stereotaxy itself, but basically it uses the fixed points. Like frame uses, you make the skull. Intrinsic points. Yeah, intrinsic points. So it has both skin-based this thing also, and there is a bone. You can use fiducials, fixed markers, where you can place some fixed points on the skull. Like we use anchor bolts in SEG, so we place them and then do it's kind of frame-based.
Frame is not that big.
No, it's not a frame. Basically, we place some 4 or 5 points on this in the skull, and then we try to do the registration based on that. We do it, but most of the times, almost all the studies have shown it's equal sub-millimetric accuracy which you can get with robot compared to the frame-based. I think.
No, so this I think, in fact, one of the first thesis in neuronavigation was mine, 2000. So that was the first time the neuronavigation was used. See, what we are speaking is when you have neuronavigation, you have 2 ways of registering. You have a bone-based markers, you have skin-based markers, and you have surface markers. So what happens is when you're doing the bone-based markers, you're going to make some burr holes, you're going to put a marker, just drill it into the bone, fix it. Then you have these fiducial, those stickers which have a central this one. So some of them use that, some of them used vitamin E capsules with the air this one. And then you have the surface markers in which you use the nose, the tip of the nose, run it around this one, which is most frequently used. So when you start using fixed markers, the accuracy improves significantly. It compares itself to stereotaxy. So you see, because what happens in stereotaxy also the frame is fixed to the skull. And then you have the box.
Hello?
The box which has those...
Yeah, hi Bhaskar.
Yeah, Dr. Milind, the other stereotaxy case has also been induced. So
Sure.
I would suggest
I would
we'll
make my
carry on
way.
the discussion while you come here and start the fixation. People can carry discussing in the auditorium.
I'll
in
make
the
my
meantime.
way. Yes. Thank you.
Thank you.
So if you use rigid bony markers for registering the image in frameless stereotaxy, it is as accurate as the frame-based stereotaxy system. If you use skin-based markers for registering the images in a frameless system, then the accuracy comes down. It's as simple as that. Because even when you do a frame-based Lexel stereotaxy, the box has the fiduciary, it's that Y shape, which I'll be coming in my talk on frames. So basically the frame is fixed to the head. It's like a rigid bony fixation.
Do you have a robot?
We don't have a robot. We don't have a robot. But the whole principle of navigation is that the more rigid the marker which you are using for registering the image, the more the accuracy. And the reason why the navigation which is normally used is not that accurate is because we use the surface marking for registering the image.
That was important because if we go ahead and get cases more and justify them, perhaps we'll be getting robots in the coming few years.
No, it is justified, sir, because just for two trajectories.
Like you are promoting stereotaxy and functional surgery. If it moves like this, then more cases will be there. And then it will
Yeah, basically, as Dwarka told, even robotic also they are using frame. There are different types of robot. Like there's a Neuromet robot where they use the stereotactic Lexel's frame only. But the fixed fiducials are even much better because you just have to nail in. Even I think Raghu has used in one of his cases where the ACTF screws, jo aate hain. You can just place them. And
Morning, Dwarka.
Bolo.
Yeah, Dr. Aditya would just say a few words about the skin incision, then we'll position and then he'll take it on from there while we are exposing it. Just a minute.
Yes, am I audible?
Please go ahead.
Hello?
Yes, Dr. Aditya, you are audible. Please go ahead.
Yeah. So if you can see, we've marked the skin incision. I don't know if it's clear or not. Now the anterior edge of the skin incision is very, very close to the superior temporal crest. And it's actually not very far from the point at which we usually make a key burr-hole. So we will basically try to make a key burr-hole as close to that point as possible, and that will enable us to have appropriate exposure starting with the sylvian fissure and almost the entire anterior temporal lobe. So this is actually not a very extensive skin incision. It is very different from, let's say, the trauma incision which you may use for accessing or doing a temporal lobectomy for trauma. At the same time, the incision has to be big enough to allow a reasonably good ECOG mapping of the anterior temporal lobe and maybe a little bit of the posterior temporal lobe. Of course, the bony exposure does not matter very, very extremely because you can slip in a grid even posterior, superior, anterior to whichever direction you want to. So this is what I typically use, and you can see all of it is behind the hairline. So this will be cosmetically very acceptable to the patient, and post-operatively the patients will not have sort of any cosmetic deformity or a visible scar.
Dr. Aditya, I
What if-
just.
So what if the hairline is far posterior?
Yes, can you see the hairline?
Yeah, we can see.
See, the hairline is beginning from here, and all of this is behind the hairline.
Dr. Jha's question is if he has a receding hairline.
Yeah.
What
Then
would
we
you
may
do?
choose to have a larger incision. Then we could begin somewhere from here, for example. So it would need a larger incision.
Yeah, my question is, are you going to fix the head on clamps or you are going to keep it?
Yes, it is slightly better to do that because you want to avoid any head movement. Supposing somebody is accessing an IV line, the body is being moved for whatever reason, you don't want the head to move. So I think it's slightly better for that to be fixed on a 3-pin. Although it's not an absolute thing, it's a personal preference. You could easily do it on a headrest or even a horseshoe. Some people I've seen do the same surgery through a linear incision like this. So that is also not a bad approach, but as I said, my usual approach is to expose a reasonably generous bit of the temporal lobe for the purposes of ECOG mapping, and especially so in a case where this is a cortical dysplasia. So I would be hesitant to use a minimal exposure, and epilepsy surgery, as we know, is one indication in which we do not try to minimize the exposure in terms of what you see when you open the dura. You have to have a generous amount of exposure to enable a good ECOG reporting. So any questions, comments? Otherwise, we'll get started.
Sir, good morning. Uday here, sir. Uday Bhomik.
Hi Uday, how are you?
Fine, sir, fine. Sir, are you going to use neuronavigation in this?
No, we could, but we are not using, I think partly because it's being used in the other case, and it's not essential, although I would say it's preferable, but it's not very essential.
Sir, can you have please a few words about the radiology part, because a few people joined late.
Acha, okay. So let me go to the MRI then.
Dr. Aditya, if it's not there, then we can ask the people to put the slides here. Okay.
Yeah, the radiology is here.
No, it's not seen there, Dr. It will be difficult to show. Can you put the slide on PIP or something?
Yes, so are the MRI images visible?
It will be very difficult to see that, Dr. Aditya.
I think then these slides can be projected in the auditorium.
These are
that will be a better option. Maybe somebody there can demonstrate on these slides. Basically, what we were seeing is a anterior basal temporal cortical dysplasia. Along with that, there was a degree of atrophy, more of a neocortical temporal atrophy, and a very subtle changes in the hippocampus on the FLAIR images.
I think for those who came a little later, this patient is a 17-year-old man who has seizure for last 11 years. Semiology is left temporal. Videology shows origin from left temporal. MRI shows gray-white differentiation loss in the temporal pole with an enlargement of amygdala. The hippocampus on the left side is normal with no atrophy or signal changes. And the PET shows hypometabolism of the left temporal lobe. So MR diagnosis is a left temporal polar focal cortical dysplasia. Epilepsy. You can just show the MR. Show the flare. Next one. Yeah.
if you can see the left temporal pole, there is a loss of gray white differentiation with fuzziness of the gray matter. But the hippocampus as such looks normal with no significant atrophy or a signal change in the hippocampus.
Read the images. Yeah. Next one.
This is not. I'll leave it. You can put it in PIP. You can go back with it.
Hello. Venkatesh. Yes. OT. Put OT on PIP. And the presentation in one screen.
So I think again the yeah.
अभी फिक्स कर दो
ज़्यादा एक्सटेंडेड है एक्सटेंड नहीं
कर देंगे ज़्यादा पूरा टाइट मत कर देना हाँ अब नहीं अभी नहीं पहले पोजीशन ठीक करना
Yeah, you can. Here, the display will allow here.
वही पता था यार 11 बजने वाले हैं Dr. Aditya? Hello?
Hi, can you hear me?
Yeah, sir.
Yeah.
Dr. Ramesh here. So there's a query in the audience that how much of head turn you prefer, or you keep it more lateral?
Yeah, so I don't like to keep it completely lateral. I like to rotate it by around, I would say, 60 degrees or so from the perpendicular plane. It's like 60 degrees laterally.
Okay. What is the advantage of that? Can you?
So basically, it helps you to have an anatomic orientation of the sylvian fissure, and you can basically judge the possible. So when we come to the amygdala resection, there is a carotid toroidal line that we use to basically guide us how much of the amygdala we should remove. So if the patient is in a completely lateral position, at least to me, that becomes slightly more difficult.
Okay. So the other thing probably might be the amount of resection of the tail would be easier to see backwards. With
The
this
tail,
angulation.
if you are completely lateral position, a tail would present to you more easily. But even in this oblique position, seeing the tail is usually not a problem.
So how many of you here do lobectomy? This. And how many would do similar positioning or would do something variants of what this? Since there are not many here, it's actually better to compare notes, otherwise it's going to become monotonous.
Why don't you begin with yourself?
No, I'm trying to talk less so that others can, otherwise it will become again. No, like what, I do not use lateral position at all for any temporal lobectomy.
Yeah.
I used to do it earlier for hemispherotomy. When we had to do perisylvan hemispherotomy, there the temporal lobectomy is a small part. There to actually do better at frontal and parietal disconnection, I used to keep lateral. Even then, never dead. In fact, I do even less rotation. My position for most transylvian surgery, not just this, is only 15-degree rotation, not more than that. What I seen in my understanding is that the more and more you rotate the brain, if you look at the position of the hippocampus is like this. So the more and more you rotate, the hippocampus is going to fall more and more away from you. So the visualization of the hippocampus will become difficult when you're going to do lateral. And especially after doing lateral lobectomy, the hippocampus falls away from you. it is not like this. The more and more rotate, the head of the hippocampus and the choroid fissure will move away from you, and it actually gives a challenge while dissecting the head of the hippocampus. So I usually just do 15-degree rotation, and many times after that, and of course for us our residents position and come, so for them craniotomy is easy with a big more rotation. Doing a temporal craniotomy with 10-degree rotation is difficult because head is going to be like that. So most often I turn the table back to my side when I start doing the hippocampal dissection. Otherwise, the hippocampus will fall away from you. It's difficult to visualize the whole hippocampus, especially the choroid fissure when there is more rotation. And I would have probably made a larger skin flap. I mean, of course, this looks small and nice, but I prefer to have a bigger opening, see better, so that it's more comfortable inside than fashionable outside. That's my philosophy. Yeah,
I agree. I think bigger surgeons make bigger flaps is the...
I am not big in any physical magnitude. I mean, others can comment how you people do what, I mean, so that...
Dr. Hari added all the points required for doing a temporal lobectomy. At our place, we use a linear incision, as Dr. Aditya had actually spoken about. So we use around 5 to 6 centimeter linear incision. Even in this, initially the temporal lobe might appear bulging with a small craniotomy, but later with CSF drainage, the space created is so huge that we would be able to slip in the ECOG grid easily in that. That is the one thing. But yes, obviously for beginners, I think it's better to take a question mark flap to have everything exposed, and then under vision, they can do the surgery. But with time, you can tailor your incision. That should not be a problem. Coming to the angulation part, I do prefer using around 50 to 60 degree rotation because that gives a better especially removing the hippocampus in toto, that generally we try to preserve the architecture and then remove the head, body and the tail as far posterior as possible. So that tail part which actually comes superiorly and then turns inside the lateral ventricle, that part actually gets better when you have slight rotation rather than complete lateral where it becomes a bit difficult. So that is the other point which I would like to add. And possibly going back till the atrium, removal of the tail gives better results as shown in the study. So that rotation might helps a lot to visualize that fag end of the tail as well.
So the other thing which intra should be kept in mind, when we start the lateral part of the temporal lobectomy, the angulation of the microscope will be something like this. We are seeing superior to inferior. I'm not sure if the angle is clear.
For the anesthesia point of view, this can...
See, the microscope will be roughly in that orientation when we start with the lateral temporal lobectomy. But then we will actually be looking somewhere, the camera angle is but difficult. So we will actually be looking something like this later on. So there is actually a 90 degree of play in the angle of the microscope. So that has to be appreciated when intra we are seeing the images through the microscope.
Okay. Hello, Dwarka. Hari? Can you...
Yes, we can see.
Yeah, okay. Now we are ready with the frame as such. So it's not new to anybody. We're just going to go ahead and position the frame. If there's anything that you would like to ask or start a discussion, please go ahead. I was just trying to show that the face bar as such, which has been removed over here, but this is something which can be used for, from the anesthesia point of view, it can become quite convenient. Only thing is that it can become a bit of a challenge at times in certain procedures, but here it's not a big issue. In this case, it's not a big issue.
Anybody in the audience who is not used to a stereotactic frame?
Sorry, come again?
No, this is a question for the audience. So,
right. So I'm sure that everybody is quite familiar with it, so I'm not going to give much of a commentary. There's no point. Pins Yeah, you give some local, yeah. Carefully, गिर जाएगा. Left side, no? Okay, come. Just can you hold it here? Okay, can we just lift the head slightly? Can you hold the frame as well? Yeah. बड़ा लगेगा इससे. I'll take this. Actually, the challenge over here seems to be her hair rather than anything else.
Hello, Dr. Milan, Dr. Manmohan here.
Hi, Manmohan. Nice to hear. You were not to be seen yesterday.
I know. Okay, I have a long story. I'll tell you.
Okay. So, why are women blessed with so much of hair? Isn't it easier to just do this on a
Dr.
bald
Milan,
individual?
you are in a public. You are in a.
I know.
You are in a public.
So I'm saying they're blessed.
Gathering, so let us keep it completely.
They're blessed. Need a longer screws.
Male, female, nothing doing. It's all
So obviously the frame is more to the left hand side, that we intend to target the left sided lesion. You want to give some local? Come. Please. Yeah, please, over here.
Just a small announcement. The snacks is ready. If you want to have breakfast, it's there in the food court.
There's something here, please.
While he's fixing the frame, I don't know, I think though it sounds futile because everybody here does it. So discussion, I'm not sure how it helps, but nevertheless, we always have this doubt, especially when we do frame for under anesthesia biopsy or for brain lesion or sometimes even for gamma knife or FEG. There's always a discussion whether you want to fix the frame and anesthetize the patient or anesthetize the patient and fix the frame. Usually we want DA so that frame itself is fixed. Earlier many times when we used to do biopsies for children, we'll ask the anesthetist to just give sedation, not put tube. So under mild sedation, we do the same thing. The part which Dr. Milin showed can be kept both front, both we can be both looking upwards and downwards. If you manage to put it upwards, you can, if the anesthetist is comfortable enough, he can intubate after the frame fixation also. The advantage of fixing the frame without giving full anesthesia is that the patient need not be on tube, on ventilator for a long period of time. You can just fix the frame under sedation, then take the patient, do the scan, whatever, bring back, and then do the procedure also under sedation. So in this
And that's
case,
the puncture side.
it takes time. Suppose here the scan is done. Suppose if you are going to do an MR guided procedure for this patient.
Hari?
Yes, yes, please.
Yeah, Dr. Aditya would just like to show a few slides and discuss a few points while we start the case.
Yeah, I think he wants to show from there.
Yeah, he'll show it from here.
Yeah, please go
Can you
ahead.
get this? Put it up there. Thank you. Perfect. Thank you. We should be okay. This is still going to be quite low. This frame is still quite low. So we are going to be made struggle.
We're not seeing Dr. Aditya's slides.
45 on screen.
I'm not sure if my phone is visible.
Anyway, we'll make a
45 on main
particular
screen,
angle.
please.
So it should be okay.
Yeah, can you focus on that?
Right.
Sure.
Perfect. So what I wanted to show is the of the
You're comfortable?
Oh my God.
Okay.
The cross section.
You want to put this
Mobile
down
on
or you're
main
comfortable like this? So let's put the bed a bit up. Yeah, okay.
Mobile, what Dr. Aditya is showing.
A lot of movements happening in the videos, so I think we shall fix it so that there is no confusion, because the PIP keeps changing from one to another.
Yeah, so is my phone visible?
No, Dr.
Phone on main screen, please.
So is the diagram visible?
Yeah, please.
So, this is a cross section of the hippocampal region, and you have to kind of get the orientation. It's not very easy to get. Now, this is medial. This is medial. We will be approaching it from this direction. Okay? So, this is a coronal diagram of when you approach the temporal horn. As you open the temporal horn, typically we reach the temporal horn from somewhere like this direction. And if you see the hippocampus anatomy, this is the coiled mass of gray matter which we call as the hippocampus. So it's actually very tiny. It presents into the temporal horn, and here would be the choroidal fissure which we will show you in
You'll keep it here, is it?
And this is how the
Because ours is in
hippocampal
the-
gray matter coils. Then there is this coil which is called as the speculum, and then there is this parahippocampal gyrus. So basically, when we enter the temporal horn, first we dilate the choroidal fissure, we mobilize all this laterally, and once we mobilize all this laterally, we see this very important arachnoidal fold going inside. So the aim is basically to remove the hippocampus, the parahippocampal gyrus, and also the fusiform gyrus which is located here on the other side of the collateral sulcus. So I would suggest that when we are operating, the anatomy is sort of, it's not
sitting in the
very easy
console,
to get yourself oriented. So maybe in the meantime you can just keep this in your mind that this is a coronal section and this is how
I
the
hope I
structures
don't
are
rip this
arranged.
apart all the day.
So that's what I wanted to say.
Yeah, can we go to the biopsy 40, please?
Yeah, you were saying something about the biopsy, Hari?
No, you want to tell because I think this is a CT guided biopsy.
Yes.
So you have already
So-
fixed the frame. So have
We've already shifted the patient down just now. The patient is just about on the way to the CT.
Yeah.
The frame fixation is done. They're positioning the table, and essentially, I'm not sure whether we'll be able to communicate from the CT console room, but I'm planning to get the coordinates in the CT itself.
No. Would you be able to show the audience here how you are marking or calculating the coordinates?
I'm not so sure, that's what I'm saying, whether I'll be able to communicate from the CT. Would we be able to communicate with them from the CT? I'll come back to you if I can. I'll keep that in mind, Hari. But
Yes,
currently what is going to happen is that the patient has moved down to the CT already. So once from there, if I can, then I will communicate with you.
Okay, sure. Thank you.
Yeah? Okay.
So how many of you prefer still stereotactic biopsy with frame in your hospitals, departments? If you have both navigation as well as stereotactic biopsy.
With frame.
With frame. Any reason why and why not?
I think with frame the accuracy is much more than the frameless.
I would prefer the frame stereotaxy always because I think that accuracy is better with frame than the frameless navigation.
No, yeah, for biopsy.
Yeah, for biopsy.
In our place, we are from Neman, so in our place, I think the most important reason why we were always doing stereotactic biopsy with frames was need for OT. Because the OT was always difficult to get. So even now we do all our stereotactic biopsies in our radiology side room, CT side room, under local, using a twistle. We do not do burrows also. That has been there from the time I have seen it last 25 years from the time I joined. All stereotactic biopsies, unless there is a anesthesia requirement or that, all stereotactic biopsies are done using a simple twistle, so that we don't need to take the patient to OT. That was the main reason. And you can, like, I completely agree with you that we need I think Dwarka is going to give a talk in the afternoon. There is accuracy is definitely better with the stereotaxy frame, because any navigation system involves correction of the images. First of all, based on the slice thicknesses, the MR itself is a fusion of 5 mm tissue. So we see a single section. If we take 5 mm slices, that one slice we see in MR is a fusion of all the tissue in that 5 mm 5 mm space fused into a single slice. So there will be an error. That's why CT is better. Second, the machine also does correction for various angles. Because when we do images with the stereotactic frame, the advice or the teaching is that the sections of the CT should be taken parallel to the base of the frame. Generally, people will do, when you just do a regular CT scan is done. If you look at the box that is kept for making scan, it's always angled to the skull. Whereas when you acquire CT scan for stereotaxy, the box has to be positioned in such a way the slices are acquired parallel to the base of the frame. So there the skull is no more in condition. The box, CT acquisition box has to be positioned such that there is 0 degree tilt relative to the base. So that you do not need further correction of the images to give you a proper coordinates. So that these are the two things which improves accuracy in stereotactic frame, especially CT based when compared to MR based. And the challenge is the brainstem or posterior fossa. That was what the discussion morning was there. Now, how many of us do frame based stereotaxy for a brainstem lesion, and how many of us would do frameless or a navigation guided stereotaxy for a brainstem? frame based for all. Yeah. So any choice of entry?
To the pons, I'm doing pre-coronal.
Yeah, yeah.
I think since I go up to the thalamus and all that, I think just going in it is much more comfortable and the access, so I feel that very good. Sometimes if it's too close to midline.
And you use MRI?
I use MRI. I do MRI T1 3D, so plain and contrast, so that has worked very well for me. Accuracy has been quite good.
No, CT, that's what I said. CT is spatially accurate when you have to mark a target. But for that, the lesion should be seen in CT. If the lesion is not seen in CT, you are not going to have anything accurate. Because if you can't see, you can't be accurate.
So many times they don't come with the CT, they come with an MRI.
No. The lesions in brainstem are inherently hypointense, may not enhance well, and you cannot see the brain as well as the surrounding structures. Whenever you are doing an MRI for a, anyway, I think we'll do the fillers. Whenever we are doing a biopsy for a lesion starting below the thalamus, from midbrain to below, we need to see whether the lesion is in the midline or paramedian, and whether they can be approached from supratentorial precoronal or from posterior. The indications for a posterior fossa biopsy are for lateral lesions. When the lesions are paramedian or in peduncle, of course cerebellar will obviously be through the transcerebellar. In brainstem, like I said, midbrain and upper pons, median or a paramedian lesions can be comfortably performed through precoronal. Those who are lateral, encroaching into the or growing into the peduncles, it is always safer to do from posterior fossa. Because if we try from precoronal, one is you will not get the angle. Second is the tent will come in your way when you try to go more and more lateral. We have done a few cases where you take a contralateral precoronal and then cross the midline and then go to the opposite side. Because as you go more lateral, the tentorial incisura is going to come on your way. It will not allow you to go in, and then you will end up transgressing more pia lesion. You should not transgress more pia. If you had to do precoronal for a lateral lesion, we have to see a trajectory which is to precoronal from contralateral going across. But now with the easy availability of navigation and transcerebellar procedure is easier. Like we said, we did not have navigation for quite some time. So most of our brainstem biopsies in the beginning, we published more than like 80-90 cases, were all precoronal frontal biopsies going down to the brainstem, even up to the lower pons we have gone. But if you have to do posterior fossa, like I said, we use all our precoronal biopsies are twistal biopsies for STBs. For precoronal, even now we do. No, even now we do. Even now all our STBs are twisted in our CTMR side room. Navigation. Just fix the frame. Just fix the frame, shift to CT, get a scan, mark, come, like how you do twistle for tapping the ventricle, just put into your once your numbers are intact, the needle will go down, the 19 centimeter radius is there, just go there, take biopsy, finish, 20 minutes procedure over, patient by another 4 hours scan and discharge. The problem is that if we have to accommodate them in the OT, it will never happen. So this has been going on from the time I have seen, and we still do, because now navigation has come, a good number of them get into OT for navigation. We were doing even brainstem biopsies with precoronal, like I was just telling children, I have done many times just mild IV propofol sedation, fix the frame, get an MRI, come back, same sedation, just do a precoronal burrow, precoronal twisted, pass the needle, take a biopsy and come out. Those cases we have used, we had the DBS Medtronic system even before we got the navigation. There we used to go there, and through the probe's eye view, we'll mark the trajectory, endpoint, and the target and the entry, and then through the probe's eye view, we'll see whether our stereotactic needle is actually going through safe areas and we are not going out of the pia zone or not hitting.
and that will be just for verification. Come back again to the frame and do the biopsy. Now, posterior fossa, if we had to do with the frame, I have done few cases before our navigation under local patient sitting like a cardiac table, burrow behind. It's a cumbersome work. Now none of us do that. Now we take the patient under lateral position, use one of the navigation system and do a burrow and do it because the frame will otherwise hinder your burrow position. So I think for posterior fossa, I think now frameless biopsy is more or less the standard of care because frame brings in lot of limitations. You have to adjust your point of entry based on the frame and the on the bars, whereas that is not required in case of frameless. You want to share anything your experience?
Who do it at our place are in OT.
Yeah. Yeah.
They leave these surgeries. Anything from the OT, I can just show you, इसको display कर दो, where you are currently, just an overview of the campus and where you are. So, so this is the lower red mark is the campus, and that is upper part is the zone by the park, and just superior lateral to that point is a circle. That is Shastri Circle. That is a famous street food area of this place. So this is the Shastri Circle. You are staying at Zone by Park or Novotel here, and this is the famous street food here. And this is the campus. We are at auditorium. This is around 150 acres. We are expected to get this space also. Then it will become around 250 acres. We are here, and this is hospital campus, this is residential area, and this is the sports complex. So this is where we are, and this is the auditorium, and we are sitting here. This is the hospital complex, this is OPD, this is emergency, this is OT, where cases are being done. This is wards, this is our skills lab, and this is where our Gamma Knife Center is going to come up. And this is neurosciences block, future, where stage 3, which is going to be developed in coming 5-6 years. So this is 2017, 4 faculty started, and this is our OPD area. OPD 1, 2, 3 room. This is a room where we library, dissection room, small dissection room before surgery going to OT, or instrument design lab, small, very small. Emergency, this is 6th floor OT block. So 5th floor is neurosurgery, and there are other departments also, but we have got 2 routine OTs out on 6th floor. So we are on this side, and we are looking towards, from auditorium we can get this view. This is our emergency, very busy, quite busy, and 6 beds a cubicle in wards. We have 2 cubicles in female and 2 cubicles in male. That is 24 wards in total. This is our ICU, 8 beds. We have just got mobile CT which is being installed now, and there is a fibroscope also for intubation. OT with all advanced microscope, drill, navigation, ultrasound. And another, this is elective emergency OT where we have got endoscope tower, Pantero 900 microscope. And this is a setup. Most of the things we have got. Gamma Knife is upcoming, robot upcoming, and neurosciences block upcoming. So, elective OT where the surgery is being done. This is our dissection lab. I don't know whether anybody will be able to visit our hospital facility or not. So just wanted to show you where you have come, just to apprise you. And this is our skills lab where we have got currently 1 microscope and 1 microscope at the OPD room where we have got brain and other things. So somebody can do that here, there also. And this is the sunset, is beautiful here. Sunrise is also beautiful here. Weather, this is starting of the best weather of this Rajasthan. And this is a lot of green here. So I think that you will enjoy us stay here. Shift kar, band kar. Thank you.
Thank you, sir. You have a dissection room in the OPD. Very interesting. How does it help? What?
There is a room, 4 room OPDs, 1 room. They have got 4 rooms in the OPD. We use 3 rooms for consultation and 1 room for library. There is a microscope, small microscope there. If ever we need to teach somebody for a short session, not a proper class, Suppose such case is planned, and during planning the resident is not understanding how the dentate gyrus subiculum or collateral sulcus or these things are not, he has forgotten it. We just take out the brain there in that room, show them the structures, then he can go around. So it is very simple, easy, available there, brain, posterior fossa. So one half of the brain, posterior fossa, cerebellum, brainstem, medulla, that is kept in that room is only for students to do something. There is a microscope, there are drills also, so small drill, not surgical drill. So we can maintain or repair our instruments also under microscope. Micro scissor, arachnoid knife, you can sharpen them, you can, if that has bent, you can correct them. So we have that microscope for that purpose. So that is available. If somebody is free, he can use suturing also. So instruments are also there, micro instruments, few micro instruments. But the main skills lab is somewhere else. That is around 200 meters away from that place. And that is a properly scheduled class when we have to leave the OPD or ward area, go to that place, and then the whole cadaver is there. Then we can do the further dissections. So we have a very mini table where we have microscope. We have two microscopes, one at OPD and another is at skills lab. That is practical because it becomes difficult to get time for the students and for us also, because we are working approximately less than half of the resident strength, what we are entitled to. So we have got 18 seats total, we get 8 or 9 residents only because seats go vacant due to many reasons. So we work with less manpower and when we manage like this.
Thank you, sir.
We use a lot of models, handmade things. We use, that is available in that room and in OPD also.
So when you say you bring out the brain, is it an artificial brain?
No.
They actually pick brain.
No, we
Even
have.
in OPD, yeah?
Yeah, in there are 4 rooms.
Okay, I'm asking
we
OPD,
use,
what is the key?
No, OPD no. There are 4 rooms. In one room, that is study room. And we have 2-3 buckets with formalin. We have kept one of the brain, posterior fossa, processed brain. So we just take it out, keep it on the cover of the bucket and show it. See, now look at where is the third ventricle, कैसे फंडिंग्स कहाँ जा रहा है, so that वो रिफ्रेश हो जाता है मेमोरी, पढ़ते लिखते उतना ही जितना सही पढ़ते हैं, वो भूल जाते हैं बेचारे. We just refresh their memory. Then and there we have models also, handmade models, रिफ्लेक्ट करने के लिए कि ये ऐसे टेंट अटैच्ड है, थर्ड नर्व कैसे जा रहा है, ये सब दिखाना. That becomes easily understandable for them. क्योंकि सारा कुछ एनाटॉमी है. That is the foundation.
Anybody wants to upload the presentations, the laptop is here. Presentations for today can be uploaded here. Alternatively, there is also an email, audiaiimsj@gmail.com. So the presentations can also be mailed on that.
अगर किन्हीं को, anybody wants to see our setup, please बताइएगा. I will make some resident to do that. Thank you. Anybody, anytime, today, tomorrow. पूरे कैंपस में घूम सकते हैं, एक कार से देख सकते हैं कि कैसा लगता है, how it looks from outside. Recently we started a very good, मतलब बहुत बड़ा स्विमिंग पूल बना है, ओलंपिक से भी बड़ा स्विमिंग पूल स्टार्ट हो चुका है. स्विमिंग पूल एक वेरी ओलंपिक से बड़ा larger than Olympic.
It is in the residential area, not in the hospital.
ये टॉवल, ये चश्मा पीछे कर देना और थोड़ा पीछे दबा दो। हाँ। तो छोटा है यार। चलो ठीक है। करा दो चेयर, इसको ड्रेप करा। Let's nibble the base, है ना?
लाइट ऑन कर दो और वो बाद में कर देंगे, पहले नहीं तो यहाँ खड़े ही नहीं हो पाएंगे। वो लास्ट लाइट ये नहीं, लाइट बंद करना भी बोला, ये ऑन करो। लाइट चाहिए, मैंने बोला यहाँ से हटा दो, वो घर तक आ जाए। वारिस बाबू कैसा है? प्रभु ऑन कर दो, हाँ बस, और सर से दूर रखो बस। अरे सर मतलब सर,
चलो जी, खुले खुले, 1 मिनट नेबलर देना यार। हाँ, नेबल करना पड़ेगा। बोनवैक्स देना है आप? Bipolar. Bipolar. On. On. Nibbler again. On. On. Bipolar again. On. Nine. Dura hook knife. Dura hook knife.
Dr. Aditya, can you, would you like to show the landmarks before we open the dura? Craniotomy, what all you have exposed? Dr. Aditya, can you hear us?
Am I audible?
Yes, yes.
Yeah. So the craniotomy just been done. I'm not sure if you're able to see that.
Yeah, you can orient us superior.
Yeah, so the craniotomy is being done. This is anterior, that's posterior, that's the temporal base. And we'll just be incising the dura shortly and doing the ECOG.
Yeah. Do you do anything different for this? Have you nibbled more towards the pole, or have you done anything additional for a standard temporal craniotomy?
Sorry, I can't hear you.
have you done anything additional for this particular case for a temporal craniotomy, like by removal of additional bone towards the base or towards the pole?
Yeah, slightly towards the base, because we do want to access the temporal base. So a little bit of exposure towards the base helps. Now the anterior burr hole, if you can see here, is very close to the superior temporal crest.
The video is not coming, please wait.
Yeah, there, I think you'll get the focus in a minute.
No, the screen, not your problem, the screen there. Please hold on.
So the anterior burr hole is very close to the temporal crest, which I can feel right here. So even through this relatively small incision, this burr hole is actually very close to the key burr hole that we make for all aneurysms and anterior circulation approaches and the Tirional approach. Very, very close to it.
Dr. Aditya, can you hold a minute? Dr. Aditya, please, can you hold a minute? We are getting your video feed.
We can't see the operative field now. So just a minute. Once it starts coming, then
So I think the Sylvian vein is very clearly visible.
Aditya, please.
Can you hear?
No, we are not getting the video feed, so you please go ahead. I think we'll have to wait. It's come, it's come.
Long.
Yeah, can you put the microscope? You've taken the microscope, Dr. Aditya?
No, we'll take the microscope in about 5 minutes.
Yeah, can you please show the, whoever is in OT, can you please focus to the table? Operative field, please.
On. कितने पे है बायोपोलर? Narrow long cotton. 15 नहीं 12.
Top camera to be adjusted so that head doesn't come on the
narrow long cotton. हाँ.
तो क्या पा रहा है?
देता रहो. कोई बात नहीं, कट कर लो. सेक्शन नहीं काम कर रहा है. नैरो लॉन्ग खूब सारे चाहिए कॉटन्स.
Yeah, Dr. Aditya, if you could take the microscope, it will be easy for us to see.
Yeah, in about 5 minutes, we are just doing the ECOG. We'll show you the ECOG recordings.
I mean, if you can do that in microscope, because for us to visualize, the tech people are having problem focusing onto the field.
Sorry?
The tech people are having problem focusing on the field, the cameras from outside. We'll probably get
सजेशन देना है ना. फिब्रिलर है, सजेशन नहीं है. कॉटन. ये कॉटन है ज़्यादा एब्जॉर्बेंट, नॉर्मल कॉटन नहीं है. नॉर्मल कॉटन दे दो, ये एब्जॉर्बेंट नहीं है ज़्यादा. चलिए, वी हैव दी स्ट्रिप रेडी. एक कॉटन देना नैरो लॉन्ग. चलो, let's put the strip. So we are putting the strip, I don't know if it's visible.
Yes.
Yeah, so this is a 4-contact subdural strip electrode, which is very commonly used in this kind of surgery. So the active contact is the one here, and the one numbered on the top is the inactive areas for our reference. So what I'm doing right now is that I am pushing it medially, bayonet, anteriorly as far as I can go, which should be roughly in the region of the dysplasia that we see. I think there might nahi saline mein डालो. Okay. Yeah. Broad cotton. Another broad cotton. Gauze piece. So, are we getting some recordings connected? It's in place. Saline. एक मिनट अंदर ही डालना, बाहर मत डालना, बाहर से ब्लड जाएगा नहीं तो. So we are getting some recordings, I think.
Can you show the screen, please? Electrocardiography screen. Can the video be focused on the ECG screen? Yeah, can you, can the videographer there focus it, yeah, thank you.
Bayonet?
I think it's have you made any adjustments to the anesthesia there, like cutting down gases?
Recording नहीं आ रहा. I think there is some vein at the temporal base. Cotton. Cotton. Recordings. नहीं आ रहा? क्यों नहीं आ रहा? कनेक्शन चेक करिए. We don't seem to be getting recordings. cotton again. इसको वॉश करना. Can we reconnect it? ये कर दिया. Let's make sure it's gone in completely and it's in the correct place. All the connections are checked. Earthing proper है. Reference electrode ठीक से लगा हुआ.
Okay, Ari, Dwarka, we are back from the CT. Can you see us?
The screen, we can't see you. Your screen is seen, but I'm not sure if that's your screen because it's loaded to the Metronic system.
Hello?
Yeah, but hello, we can't see your video.
You can't see the screen. Okay, that's okay. He's
Yeah,
connecting
we got you now. Yeah.
Okay, so I'll see if I can. You're seeing me on the thing.
Yes.
Can we show the patient?
Recording नहीं आ रहा.
So can you show the patient?
नहीं आ तो रहा है recording.
Okay, so Ari, Dwarka, can you see the patient?
Yes.
Okay, so we are back from the CT. We've got our coordinates in the CT itself. So just to give you an idea, the X is 110, the Y is 102, and the Z is 75. Okay, we are also going to get the CD and merge those pictures with the MRI, which was a navigation sequence which was done earlier for the patient. And we are about to start the procedure. And otherwise, nothing much. I was just earlier mentioning that approximate XY and Z coordinates, XY coordinates help us give the exact location of our burr hole entry point, which can be noted from the frame itself. So if there's nothing else, we can just proceed and start draping and draping. It's a straightforward thing otherwise.
Dr. Milling,
Yeah, any other questions that you have?
Yeah, Dr. Milling, just one question. This lesion is more posterior callosum or mid callosum?
Come again?
The lesion is at mid callosal or posterior callosal level? Do you think?
It is at the splenial level.
So you,
there is. We will. Can we show the scans? We will just display the scans out for you.
Yeah. Do you want to go more posterior for entry or?
No, I'll just show it to you. Over here, it appears as if it is quite anterior, whereas it is not. If you see this, I'm just moving the camera. It's a reasonably posterior entry.
Okay.
And as it comes, and I don't want to go too posterior as well. I'm interested in hitting it. We should be able to do that. We are just trying to retrieve the images so that you can have a look at the MRI scan as well.
Okay, sure. Thank you.
So he's connecting. So just run it, scroll it through. So this is the MR. You can see the splenium involved, and as the lesion comes up, you see that part which is more or less on the left hand side. That is more anterior to the splenium.
Yeah.
Can you see that?
Yes,
Hari?
yes. Yeah, it's a mid callosal. It's anterior to the splenium.
Correct. So it is the lesion is involving the splenium posterior, and significant part of it then comes anteriorly. So we're going to take advantage of that rather than
you can zoom,
going posterior.
You can zoom the image. You can stop it at the point and tell us where exactly you mark that target so that.
Right. So this is, I don't know whether you can visualize the screen and my marker, but this is exactly the arrow which it is pointed to. This is where our stereotactic biopsy or target is. Can you see my dark arrow there?
We cannot, but we can see the axial slice, so we can make out that it's at the.
Yeah, so I'm just moving the arrow. So can you appreciate the arrow around the lesion?
Yes.
Can you appreciate the arrow?
Yes.
Yeah, so basically, and can you appreciate that there is a slightly hypointense shadow here?
Yes.
Yeah, so very close to that, we are trying to target this part of the lesion. Okay?
Thank you.
Fair enough, everybody agrees with this?
Yeah, thank you. Anybody who's...
I didn't want to stay very superficial as well, but then essentially problems of a frame-based procedure can crop up if you are very, very superficial. This is obviously advantage of this being that you are anterior to the motor strip as well. So here we can see the hand knob.
So Raghu,
yeah.
So did you plan the trajectory also, if you can show that to others?
We are still waiting for the images to come from the CT and we need to merge the CT and the MRI images. Someone is fetching the CD for us.
Okay. You want to stay close to the hypointense area or probably come more towards the center as the target? Maybe once you get the CD, you will replan that, is it?
Correct. So the trajectory planning, I will need to merge those images. But at the moment, I have collected the coordinates directly from the
from the CT console
itself.
Yeah.
You have done a trajectory planning on this? Just show it, please. You're waiting for the images to be. Yeah. Okay, you've done a frame registration. Sure. Contrast.
Am I audible?
Yes.
Yeah, so now in the ECOG, you can see a lot of spikes and in fact all the 4 channels. We have used a 1/4 subdural strip and you can see multiple spike discharges which are propagating across all the 4 electrodes in channel 1, 2, 3 and 4, which is what I would expect because all the 4 contacts here are actually in the anterior temporal area. So this was basically to demonstrate, I think the real use of ECOG we will have when we are judging the posterior margin of the resection.
Dr. Adit, if I may ask, what anesthesia are you using?
So I'll ask the anesthetist to tell us, what is the anesthesia protocol you use for epilepsy surgery? If you can speak, they can hear you.
Okay, so good morning everyone. So during, while the ECOG monitoring is planned, we plan on avoiding higher doses, higher concentration of inhalation agents, and we stop the infusion of propofol if we are giving total intravenous anesthesia and keep the patient on dexmedetomidine infusion.
No, I was just
can ensure adequate neuromuscular blockade.
trying to see
there is
how
always
I
a
actually
risk of
get.
awareness
I can
during
view this. Why is it
that has
not
to be
showing me
explained to the
the?
patient. There's some chance of awareness post-operative recall, but
Correct.
it's
So I'm
not
looking at
troublesome
that.
if patient is explained about it. And if also I would like to add that if we have to increase the epileptogenic activities on the recording ECOG, we can always increase them with the help of drugs like etomidate.
Thank you.
That's the protocol.
Right, thanks Dr. Swati. So I think we will get started on the procedure.
What is
So let's take the microscope.
What is the BIS for the anesthesia for epilepsy? What BIS value you are maintaining?
Dr. Swati? Dr. Swati from anesthesia? What is the BIS that you keep while doing?
Sir, the BIS we take in this case is around 50 to 70.
Okay.
Although we don't follow the numbers much, but we follow the BIS waveform more.
Okay.
The patient should not be in a deeper plane of anesthesia. That is what we target according to the BIS waveform, rather than the absolute numbers.
Okay, thank you.
So we used to actually skip medications on the day of surgery. Earlier when we used to do electrocardiography, to get the recordings, we used to actually skip the medicines in the morning. That can work both ways. You can have an intra-op seizure, or the patient can have post-op because the levels will drop and it will take 24 hours for the concentration to go out. So nowadays, sorry, I had a thunderstruck. My teacher sitting there. So, so nowadays we don't stop medicines, and like he said, we don't give inhalation anesthesia, stop propofol. And now Dexmet actually helps one to maintain analgesic anesthesia, as well as it can enhance the spikes. And if you need further enhancement, sometimes other drugs like sevoflurane can actually enhance, but they don't use that. Standard is to reduce the inhalation agents and give Dexmet, and that is sufficient. And now we hardly had to stop medicines to get the spikes.
Dexmet is only for analgesia, so there is no pain if Dexmet is being given. That helps to control the patient.
Regarding the recordings we saw, the ECG recordings, we saw those, all the 4 leads having a burst kind of thing. And that was, I think, 1 or 2 every page. So that most often we see this pattern in FCDs. And what is the grading do you follow? Do you have any...
We don't follow the grading. I think you had Sarath and Manjari had made the grading, so you follow your grading. So what we do is
focus कैसे हो रहा है? Focus speed बढ़ा दीजिए.
Electrocardiography is very diffuse in dysplasias.
No, but focus speed is very low.
Less in case of cavernomas and gliosis. So we don't.
Or illumination.
And then,
illumination.
You're not able to see the videos, but technically or optimally for this, we should map different areas. We should do superior, middle, and inferior as well as subtemporal, and see what is the pre-resection FCD, and then do the resection, and then go back and do recording of the residual areas, the margins, and see. And papers say anything more than 75% reduction of the pre-resection FCD, pre-resection ECGs is good. All said and done, this is an interictal recording, so we have to be careful before putting all the money in that. You can have sometimes.
You have one machine over here or 2 machines?
Because this is interictal, patient is not having seizures. And
you have one machine, navigation system, or you have 2 systems?
Of recording ECG spikes also. That also is not a kind of goal. You may have to titrate your surgical. If you have got more than 75-80% reduction, and if you think you have reasonably removed, you can stop. And eloquent radii also will come into the picture when you start. If you have let's say you're operating right frontal, you still have some spikes, you can go ahead and resect. Here, if suppose after resection, if there is spikes coming from posterior temporal, obviously the surgeon is not going to resect. Yes, Dr. Milind.
Hi, Ari, can you hear us? So this is something which we are showing you the initial plan on the MRI scan. So this is the target that we have chosen, and at the entry point as we come up, I'll just show you that there's a nice little cortical vein anteriorly. So you see this, I'm just going to hide. So this is, I'm just going to hide the trajectory. If you see this.
No, that blue line is the trajectory that you have marked, Dr. Milind?
Correct. So I'm just going to I've made that invisible, but I'll make it visible now. Can you see that?
Yeah, but is this the final trajectory, or you are
No. I'm still waiting for the CT images to be merged. This is still, so obviously I'm trying to avoid the vein. Here I can see this vein here. You see this vein over here? Yeah, you're also audible, I think.
Yeah, so we are starting now. This is the superior temporal gyrus. That's the middle temporal gyrus. Okay. So as I said, I will be going in from this area, avoid going into the superior temporal gyrus, especially on the left side. This arterial channel I will totally avoid.
Dr. Aditya, I think you have to orient us Cillian-Fisher base pole because it's difficult for.
So let me orient.
Because
is this better?
The microscope is also we are not getting the. If you can keep the temporal base to our base, it will be easy for people to.
Oh, you need to rotate the image, is it?
Yeah. Can you show the base?
Yes, this is the sylvian vein. That's the frontal lobe. Okay. That's the temporal lobe.
Okay. Yeah.
Okay.
Yeah.
This is the base.
That is the pole.
That is the pole.
Okay.
Yeah, that is the pole. This is anterior temporal, and towards there will be posterior temporal.
Yeah.
You can see the sylvian vein very nicely.
Yeah.
Okay, so we'll start. Basically, what I just did, if you saw the thread, we have measured 3 centimeter, which is coming to around this sulcus. So we will knock off this bit of the anterior temporal lobe. I will avoid this artery completely, and I will take off the other sylvian small vessels which are going into the anterior temporal lobe. On thoda irrigation.
You are going to preserve the superior temporal gyrus, or you are going to remove?
Yes, this is the superior temporal gyrus. Only a slight bit of it I will take off here, but of course the, let's say, more than 90% of superior temporal gyrus is going to be preserved. On.
Can you hear me?
बस saline दे देना. Saline.
Coming back to this theatre, can you hear me?
Yes.
On.
Okay. So if you see on the MR, which is just without the, it is not a stereotactic MR, it's a post-contrast 3D MRI scan. So this is the hand knob, quite nicely seen. So we are quite in front of the premotor strip as well, and our trajectory is safely into it. But as you come towards the entry point, there is this nice little vein there. Yeah? So that is the only concern. So I'm going to just, I've set an entry for myself so that I avoid the vein. But let me see, once I get a stereotactic CT, how do I work out my exact coordinates?
Dr. Milind, would you like to go more lateral than medial?
Well, I don't want to have too much of an angulation, Ari, because more the angulation, the higher the chances of me causing any problems. But yes, if that is what the CT desires or CT tells me to do, I will do that.
No, the more and more medial you go, you'll be close to the sinus and all the converging veins. Likely.
Well, I'm so far at least on the MRI scan, at least I'm seeing a nice little thing. But obviously, I'm quite happy to change my entry point depending upon what the stereotactic CT shows me. Yeah. But yes, this is not the final entry point. We'll just calculate once we have the merged points.
Dr. Milind, any thoughts about the entry from the posterior aspect?
I don't want to go too posterior because it is unnecessarily going to go through the motor strip.
Not, it was coming from the parietal.
Sorry?
Coming from the parietal, posterior, 1/3 of the box.
I was planning to biopsy the mid-callosal point rather than the splenial lesion.
There is going to traverse through the motor fibers.
The motor, this is actually, my entry point is way premotor. So it is not going through the motor tract at all. It is going through the premotor area. I'll show it to you once we have the final stereotactic CT merged with the MRI scan. Obviously, the idea is to avoid the motor cortex. There's no doubt about that.
And we get the microscope feed, the main.
On.
Can we get the microscope feed, the main picture, video?
So I'm taking off approximately 3 centimeters of the anterior temporal. On. So anterior temporal, there is a lot of atrophy which I can see, and I'll show you why I'm saying that. Narrow cotton. Narrow cotton. Yeah, thanks. Now let's go towards the Sylvian fissure. As you can see now, I'm changing the direction of the microscope view. I'm looking more towards the base. Can we increase the light intensity? 95 पे कर दीजिए. कितना है? 95 है. Bipolar, narrow cotton. Now, towards the Sylvian fissure is the most important step of keeping the arachnoid intact. So, am I audible? Am I audible? Am I audible?
Yes, sir. Yes, sir.
Yeah. So, I don't know if you can appreciate, I am using the suction very carefully to keep the arachnoid intact. Now, in these kind of situations where the anterior temporal lobe is very atrophic, the arachnoid is also very, very flimsy. It's not like the normal arachnoid which you can handle very forcefully. So what I'm doing, and I would say this is a very, very important step in this surgery, is to make sure that you keep the arachnoid fully preserved. Can we get more light? Are we at 100%? नहीं 95 करो यार. ये तो और कम लग रहा है मुझे. अभी भी कमी है. Anyway, so bipolar. So you can see I am giving counter traction on the arachnoid by the cotton so that I don't tear the arachnoid. On. Looking to look at the base. लाइट थोड़ा बढ़ नहीं सकता है. बायोपोलर. ऑन. ऑन. इरिगेशन नहीं चाहिए अदरवाइज ना. ऑन.
Sir, can you zoom a bit so that we can see more clearly, if possible?
On. So what I'm trying to do now is to coagulate the pia all around, and basically the first step is to mobilize the lateral part of the anterior temporal lobe, because that is coupling the medial structures where we eventually want to go to. Micro scissor. Bipolar. On. Micro scissor. Bipolar. On. Off. Micro scissor. नहीं वो ऑटोमेटिक फोकस वाला ऑप्शन वो कम कर दो ना, वो बंद कर दो ना. एक इसमें होता है, there is automatic focus.
Okay, Ari, Dwarka, Manmohan, am I audible? Yes. Okay. So we merged the CT and the MRI scan, and effectively there was this concern which was raised by you and Manmohan as to we are fairly close to the motor strip. But if I can just take you up over here, so this is the hand knob area here. See this hand knob area here? Yes. So it should be reasonably okay as far as the target is concerned. And as far as the entry point is concerned, so I've chosen this, arguably one can argue with me saying that you can be a little more lateral and things like this, but I do not want to go a little too anterior or too lateral, purely with the idea that I want to keep it as perpendicular as possible. And I want to avoid any major vessels over here. And if you focus on the probe's eye view over here, on the surface there is a nice cortical vein anteriorly, but I'm entirely within the gyrus to start off and to finish. So I'm avoiding any sulcal vessels and I'll be into the lesion. So that is what I'm planning to do. As far as the CT part is concerned,
Dr. Milind?
Yeah, hi.
Navneet here. I think we are directly entering through the motor cortex. If we see the most superficial guy, right?
I was just showing the same. If you see the, 1 second. So now if you just follow on the probe's eye view, I'm just at
this is the circus.
Coming. So now you see this is just at the anterior aspect of it. So this is the hand knob area. Yeah? You agree with me? This is the hand knob area. So we are just in the premotor. And the reason I'm avoiding anything anterior or anything lateral is I do not want to come. I would like to stick to the principles of 90 degree to the tangent of the skull. The trajectory is preferably 90 degrees to the tangent of the skull, so that I do not miss the target by any chance.
Dr. Milind, if we go more laterally and more posteriorly, that would have been more in the post-sulcal gyrus and in the from the lateral to medial. That would have been a
I
safer
agree that
trajectory.
I agree that you have a different viewpoint, but I do not want to come from posterior to anterior. I would rather stick to a simple, straightforward entry point rather than coming from posterior to anterior. And I just need to make a couple of passes, and that should be good enough, I think. So anything which is going to come from more posterior, I would be essentially, if I try to go posterior, then I would essentially be traversing more through the fibers rather than without the fibers. Here it is probably going to be just straightforward entry in and out along the direction of the fibers.
Morning, sir. This is Jitin, sir. Sir, can we go anterior to the cortical vein, which is seen on the MRI?
Again the same principle. If I go anterior to the cortical vein, which is something which Mohit was also asking me over here. So if I just show you over here, if you focus on the sag, can you see my arrow?
Yes, sir, we can see.
Can you see my arrow?
Yes, sir, we can see.
So if I'm coming like this, then there is a good chance that I can do that. That is, the only thing is that, the intracranial length of this probe is just about 3.5 centimeters. So what happens is, the shorter the intracranial length of the probe, the higher the chances of you missing the lesion. Though over here you can say, can you choose a slightly more anterior thing and avoid, which is a fair thing. But again, if you see it on the axial now, my vein is going to continue like this. For hypothetical purposes, if I reset my entry, let's make a separate plan. Correct, no? So I have set a new target, and I am now planning to see if I can come a little more anteriorly. And laterally as was desired. Again, this is from the gyrus. So this is the other trajectory which you can have. So I would definitely not go by the posterior route. I would definitely think in terms of getting as much of direct entry and sticking to the perpendicular, because I'm quite comfortable making sure that this is something which is a couple of biopsies. And these are the two targets that have been chosen. So now it is pick and choose as to which one does one want to do, but I'm comfortable with both these. Obviously avoiding the vessels. So let us see, we stick to the plan 2. Select, orientation, lateral right, done. So these are the coordinates. So the X has come to 102, that is what we had seen earlier as well on our CT. The Y here has come as 102. We had chosen a Y of 110. Sorry, X was 110. Y was 102. So the Y is more or less the same, and the Z over here is 70. We had selected a Z of 75. The ring is roughly around 70, which is okay. The arc is around 15 degrees, 14 degrees off the perpendicular, which is not too bad. That's generally our STB, well within the STB parameters. Now, if I go to plan 1, plan 1 is, this is what more of what we had decided. We had decided on an X of 110, no? So this is 108.3, Y was 102, so this is a Y of 98, Z is 68, we had decided a Z of 75, and ring is about 95, and this arc is about 80, which is slightly going from medial to lateral, that means. The arc is 80, which is slightly medial to lateral, but that was to avoid the vein as such. So we have these two entry points. I would definitely not go from posterior to anterior. I think that would be actually a little bit of a challenge as well. Okay, any other questions? Otherwise we would proceed. Am I audible?
Yes, sir. Yes, sir.
Yeah,
please
okay.
go ahead. Please go ahead.
Okay, okay. Let's start there.
Yeah, Dr. Aditya, would you like to describe? Dr. Aditya?
Yeah, am I audible?
Yes,
Sorry?
yes. Yeah, please go ahead.
Okay, so you can see we have been able to preserve the arachnoid. You can see the MCA pulsating here. And the entire Sylvian Fisher arachnoid is nicely preserved. We don't have a single rent anywhere from top to bottom. That is the region of the uncus, which I am working on right now. And this is basically the lateral temporal lobe, which I have largely mobilized. You can see I made almost a vertical disconnection. I will shortly be taking off this piece so that we have space to work in, and then I will continue with removing the uncus completely, which is right here, and subsequently we will enter the temporal horn somewhere here, and then we will do the rest of the surgery. So any clarifications, questions, anything?
Sir, how much temporal lobe you remove? Lateral
3
temporal neocortex?
centimeters, being the left side. On the right side, obviously, one could remove more. On. So right now, my interest is basically to lop off this hanging lateral temporal lobe. Typically in MTS cases, as I'm doing it, the temporal horn opens somewhere here. So, cotton please. So this is the region of the uncus. As I said, in this particular patient, the arachnoid is very, very fragile and floppy. That's why it's taking me in some extra effort to keep it preserved. Because I know the moment my suction touches this arachnoid, it will burst. So I'm doing counter traction with the cotton, at the same time using my suction at precisely a certain suction pressure to keep the arachnoid intact. Okay, now we just take this thing off, on.
Can you intraoperatively appreciate the difference
This is not normal tissue. You see this grayish piece of tissue?
Yes, sir.
This rubbery grayish piece of tissue, I don't think this is normal tissue. So we will send it obviously for the histopath, and I'm pretty sure something will come out. I think the appearance is very, very striking if you can see. This is very grayish, rubbery in consistency compared to more normal looking tissue at the depth. On. very, very fragile arachnoid. Even if I suck that brain tissue, the arachnoid is likely to rupture. Bipolar. Basically, I'm creating a vertical trench, and now I'll just amputate this piece of hanging tissue on. And we are lucky, here we have entered the temporal horn. Okay? I'm not sure if you can appreciate, we have entered the temporal horn right here. And what you see right in front of us is the hippocampus, this. Am I audible?
Yes, sir.
Yes, yes.
Yeah, so this is the temporal horn, and interestingly, this is the amygdala, which forms the anterior and antomedial boundary of the temporal horn. And I can see the amygdala is not normal. It's much more grayish pink compared to what I would expect. So this is the amygdala, that's the hippocampus. We will, of course, as we go in, we will see further anatomy also. So let me just disconnect the lateral temporal lobe on. So this is the lateral temporal lobe specimen on micro scissor. Yeah, just hold it for a bit. I think it's okay. Bipolar on. Okay, so that's the lateral temporal lobe out. And the next, what I would like to work on is the amygdala. But that is after we reach the choroidal fissure. Before that, what I would like to do is remove a bit of uncus so that it clears some space for me to do the amygdala resection and to visualize the hippocampus more clearly. Bipolar. So again, working on the uncus purely with my suction, and as you can see, the arachnoid is very, very flimsy. I'm concerned that at any point it can just give way. And that there, so not on unless I say, huh? Don't do the bipolar on unless I. Okay, so that is the uncus being taken off. That is a bit more of the uncus being taken off. I would love to go around it and actually take all of it for histopaths, but I think that maneuver will tear the arachnoid.
You can use a dissector and dissect it off.
It's the arachnoid, it's very flimsy and adherent. I don't think it will be safe. So you can see now Let me show you some interesting anatomy here. And this is the reason why I don't want to breach the arachnoid. See, these are the important PCA perforators. And these have to be preserved, and they are right close to the uncus.
I think you're already seeing third nerve choroidal.
Yes, absolutely, absolutely. So I'll just orient you, and we will see all the interesting anatomy that we see in this approach. Okay, so let me zoom it a bit. Are you in focus?
Yes, please.
Yes, yes.
Are you in focus?
Yes, sir.
Yes, we can
Bipollar. Okay, so let's see what we have here. I think probably that may be this may be the choroidal coming from the ICA. That of course is the PCA. That big one there is the PCA with some perforators coming out. That is the third nerve. And this is the edge of the tentorium. You can see the white free edge of the tentorium very clearly.
Yes, everything is.
And here, as I said, the arachnoid is very, very flimsy and stuck to this piece of tissue, which we don't need to chase. Now, next, what I will do is go to the temporal horn as we saw it. And remove all of this tissue. All of this tissue has to go. Now that's the ICA line very, very roughly, and the choroidal fissure will be somewhere there. So basically all of this tissue needs to come out. All of this tissue needs to come out. I'm dilating the temporal horn. You can see the choroid plexus. I'm not sure if you're able to see that.
Can you move the microscope? And
I will do that. I will do that. Let me just open up the temporal horn. Okay, so that is that. And all this stuff we have to remove. This is the amygdala. Can we have a retractor, Leila? Let me put a cotton there. Bipolar cotton. This is not normal. This grayish appearance is not normal. So I think we probably made a right decision by planning to do a AMTL rather than a ECOG guided dissection. So temporal horn, and can you see the choroidal the choroid plexus?
Sir, Dr. Aditya, if you bring it to the middle center, because we are also hampered by another small VIP screen in the base.
Understood.
Yeah,
Understood.
so if you
So
can,
let me,
yes, thank you.
Let me magnify that for you. And in fact, I also want to see the choroidal fissure. Okay, so temporal horn, and beneath my bipolar, can you see the choroid plexus?
Yes, sir.
Yes.
And let's see where the choroid plexus is coming out from. That is the choroidal fissure, which we will see in a short while. We will see that in a short while once I have a retractor in place. Right now, I'm just going to use my non-retracted time to take away the amygdala. So I have a rough idea of the lie of the choroidal fissure, and I will basically remove all of this stuff. On, try to take some of it for biopsy. Biopsy forceps. Sorry. Biopsy number 2. First है lateral temporal lobe, second है amygdala. It's very friable grayish tissue. Bipolar. On, off. Very fragile arachnoid which is visible through this thin layer of tissue. Cotton please. So largely I would say the peripheral part of the amygdala is out. It was bulging here if you remember. So that part of it is out. Cotton. If you look carefully, you will see the arachnoid hair intact. It's faintly, translucently visible through the normal tissue. Rest of this work we will do when we're disconnecting the foot and the head of the hippocampus.
Do you remove this much amygdala every time, Dr. Aditya? Because I think
Yeah.
at least I do not remove all this. But
okay, we have a retractor. Yes. So in this case, because of the slightly bulky amygdala, we are needing a retractor at this stage. In my typical MTS cases, I do not use any retraction until I am looking for the tail. नहीं यार ये ना थोड़ा सा longer चाहिए, longer. एक मिनट, let me try. ठीक है, टाइट कर दो. Actually, I need a longer retractor, I think. Longer चाहिए. I need a longer retractor. The blade needs to be longer. अच्छा. Let me do that. Okay. So, perfect. Can we tighten that? Excellent. Perfect. No, just loosen it. There is a perforator there which I don't want to put too much traction on. Oh, okay, yeah. On? Okay, thank you. Right, so let me get that in the middle of the field. Let me take away that cotton bipolar. So, am I in focus?
Yes.
Perfect. So, what you see here is, of course, a very important perforator going here, which we need to preserve. But you see the choroid plexus popping out from the choroidal fissure. Microdissector, normal microdissector. Now, here also we need to take very special care to preserve the arachnoid. And what I basically begin by doing is just to dilate the fissure a bit. There's a large vein, so in this case I can't dilate the fissure, it will rupture this vein. So I am just going beneath the foot of the hippocampus here. Okay, let me follow a point where arachnoid seems to be preserved. I see that point. Microdissector. So this is a point at which the hippocampus is thinning out. This is the hippocampus. This is the hippocampus. And it is thinning out. If you remember my coronal diagram which I showed, choroid plexus, choroidal fissure, this is the hippocampus, all of this, foot of the hippocampus, and I have a point here where arachnoid is preserved. So that's where I'm going. You can see I'm peeling off the foot of the hippocampus from the intact arachnoid. Can you see that?
Yes, sir.
So I am basically peeling off the foot of the hippocampus from the intact arachnoid, and what you see below the intact arachnoid is the brainstem. Bipolar. Bipolar. On. Okay. So let me do that a bit. Once this arachnoid, this hippocampus is completely peeled off, round body dissector. Do you see that? So the arachnoid totally preserved and the hippocampal head being peeled off from the arachnoid. And as I said, that's the brainstem below. Cotton please. So let's cover all this with cotton. Yeah, cotton. It will help to put some pressure, and all this capillary bleeding will stop by itself. So now the hippocampus is disconnected. We can just peel it back and follow it. Round body dissector. Now what I'm feeling back here is not the parahippocampal gyrus. This is actually a part of the inferior temporal gyrus. Below it is the fusiform gyrus. But we know that all of this has to come out. So that's why I am trying to get all of this on block. Now we come to this very interesting arachnoid fold, which is very important to understand in this operation.
Can you do reverse Trendelenburg a bit, please, sister?
So,
reverse Trendelenburg so that we can
bipolar.
actually have a bit of.
Now this is what I was showing you. So this is medial. So this is the hippocampus.
Okay, that's fine. Thank you. We are in position now.
Top of the parahippocampal gyrus.
Can you hear us?
This was the hippocampus here. It was lying on top of this parahippocampal gyrus.
Okay.
Dr. Milind, can I just wait for 5 minutes? Dr. Aditya is just explaining a step.
Okay. So
Now,
what we'll do is we'll proceed with the bore hole in the meantime.
This is the collateral sulcus. This is the collateral sulcus. This whole band of arachnoid is basically, this whole band of arachnoid is between the parahippocampal gyrus, which is not this is the hippocampus. That's the parahippocampal gyrus beneath my bipolar. And this is the collateral sulcus, beyond which is the fusiform gyrus.
The hippocampal sulcus.
I mean, it's called by different names, but that's broadly what it is. Now, I will now come from laterally, and we can see that arachnoid fold from the other direction.
Dr. Aditya, the fold of pia mater which you showed, that probably that is a hippocampal sulcus, which is actually it's also called as it joins the fimbrio-dentate sulcus. So that basically the dentate gyrus can be seen through that pia actually, if the medial part when we lift it up.
Yes, so that's what I'm mobilizing. And now let me see the hippocampus from this side. Perfect. Now I show you some more anatomy. So we have started to see the fimbriae of the fornix. Beginning of the fimbriae of the fornix. And as I said, this is the collateral sulcus. The parahippocampal gyrus continues as the lingual gyrus. Cotton. Narrow. That is the brainstem, okay? And this is the fusiform gyrus lateral to the collateral sulcus. On. on. So the whole point of keeping all this arachnoid intact all through is that you can be very selective in the fine blood vessel that you coagulate. On, 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 micro scissor. With all this mobilized, basically then we will need to follow the tail of the hippocampus. Bible. And any of these blood vessels can be coagulated without any fear because we know they are going into the fusiform gyrus and the parahippocampal gyrus. On, micro scissor. बाहर खोलो on Now with all this done, we basically follow the tail of the hippocampus. Release. Apply. Okay, thank you. So now here you have it, the hippocampus, and you can see the choroid plexus. Can you see that?
Yes.
Am I audible?
Yes, yes.
So choroid plexus, fimbria of the fornix, which is like a ribbon, and basically if I can take off this cotton, what my bipolar is placed on is not very far from the tectal plate of the brainstem. So that is very close to the tectal plate of the brainstem. The peduncles, as we know, will be there, where we saw the third nerve. And here we are very close to the tectal plate of the brainstem.